Hi, welcome back to Nurse Ed Scholar. So today in the cardiac series, we're going to talk about hemodynamics. Okay. So when you get to the NCLEX and you see MAP or cardiac output, preload, afterload, wedge pressure, and the word pressors, I don't want you to immediately freak out. Okay. I don't want you to think, man, I should have paid more attention in my ICU lecture. I want you to stop. I want you to calm down because you're not alone. I mean, hemodynamics, it sounds complicated, you know, but realize the NCLEX really isn't expecting you to calculate an advanced ICU calculation, right? It's not testing whether, you can manage a Swan-Ganz catheter. The NCLEX is really testing whether, you understand, is perfusion adequate in your patient? Are your patient's organs perfusing, right? So today, I'm going to do my best to simplify MAP, which is mean arterial pressure, cardiac output, SVR, preload, afterload, what's wedge pressure, and when do you use pressors? Okay. And I'm going to try to make it, make clinical sense, so you're not overloaded, you don't panic, just recognizing pattern recognition. Okay. So let's start. What in the world is hemodynamics, right? Well, hemodynamics is simply how well the blood is moving in the body. That's it. How well is the blood moving in the body? You know, Hemodynamics really answers one question, and we've said it already. Are the organs getting enough blood? Because when perfusion drops, the kidneys fail, the brain becomes confused, the the skin becomes cool, lactic acid rises. You know, Hemodynamics is all about protecting perfusion. And that's basically what we're going to learn today. So let's start with mean arterial pressure, MAP. Okay. So MAP is the pressure that pushes blood into the organs. So think of it like, so you have your systolic and your diastolic, right? So your systolic is the squeeze, and the diastolic is the resting pressure. So the MAP is the average pressure the organs feel. Remember, there has to be a certain amount of pressure in the body to get that blood to perfuse the organs, okay? So a normal MAP, mean arterial pressure, is between 70 and 100. Okay. Now, in one of my other videos, I talked about it, but remember, if the MAP is less than 65, that's letting you know your organs are at risk. Your organs are not being perfused as well. Okay, so the normal MAP is 70 to 100, and anything less than 65, that's letting you know your patient is getting in trouble. Okay. Now, you don't need to memorize the full formula on the NCLEX, but I have it here, just in case you need it. So MAP um, is, you know, uh, almost equal. I mean, I don't want to say equal, so um, uh, near, a certain number. So it's never exact, but you're going to take your systolic blood pressure plus 2 times your diastolic blood pressure. Once you get that number, you divide it by 3. Okay, so here's an example. If your patient has a blood pressure of 90 over 60, right? And you plug those numbers in. Remember, multiplication comes before addition and subtraction. So you're going to take that 2 and multiply it by your diastolic blood pressure. So that would be 120. And then you would add it to the systolic blood pressure, which is 90. You take those two numbers, add them together, and divide it by 3. So if a patient has a blood pressure of 90 over 60, their MAP is going to be approximately 70. Now the range is 70 to 100, so it's still within the normal range, borderline, but acceptable. Okay, let's do another one. If your patient's blood pressure is 80 over 40, okay, and you're trying to calculate the MAP, you would take that diastolic blood pressure, multiply it by 2, which will give you 80. Then you add it to the systolic blood pressure, which is 80. Then you take that number, divide it by 3, and you'll get approximately 53. It's like 53.3333, but 53. So that 53 is less than 65. So that's letting you know that your patient is in the danger zone. Remember, a MAP less than 65 means that perfusion is compromised. So you as the nurse, your main priority is to support the patient's blood pressure. So you're going to call the provider, let them know what's going on, and wait for the orders so you can perform those interventions. Okay. Now let's kind of look at the big picture, and then we're going to break down each component. So blood pressure depends on cardiac output times SVR. And what SVR means is systemic vascular resistance. And we're going to talk about that in a few minutes. And cardiac output depends on heart rate times stroke volume. And stroke volume depends on preload, afterload, and contractility. So let's break all of this down. Now, when you're looking at cardiac output, we said cardiac output is equal to heart rate times stroke volume. So that's going to tell you, cardiac output is going to tell you how much blood leaves the heart every minute. Okay. And if that cardiac output drops, the organs don't perfuse. And so cardiac output is going to be affected and it's going to drop if the heart rate is too low. If the heart rate is too fast. It's just pumping and it's not allowing the heart to fill. So when it contracts, it can perfuse properly, right? So another reason cardiac output is going to be low is weak contractions. So that would be seen with heart failure. It's just is not pumping effectively. And then low volume, bleeding. Okay, so those things will cause your cardiac output to drop. And remember, cardiac output is how much blood leaves the heart every minute. So when you see a patient with bradycardia, so low heart rate, and hypotension, think cardiac output problem. If they have tachycardia, the heart's beating too fast, and hypotension, think cardiac output problem. A low ejection fraction, so that means that the heart isn't pumping effectively, or shock, all of those will let you know that the patient is having a cardiac output problem. Now let's move on to SVR. So SVR is systemic vascular resistance. Okay. So if the SVR, the SPR, SVR, systemic vascular resistance, what happens is that it means that the vessels are too tight. Okay. Um, if the SVR is elevated, that means that the vessels are constricted. There's vasoconstriction going on. And that's going to cause the pressure to increase. And then that means the heart has to work harder to push through those constricted vessels. Okay. So if SVR is low, so low systemic vascular resistance, that means that those vessels have dilated. So the pressure drops. Okay. So in septic shock, what happens is that there's vasodilation, and then that is leading to low systemic vascular resistance, which is going to lead to hypotension. And you will see orders for vasopressors. Okay. Now, what'll happen is that as the blood pressure starts to drop, the body, of course, is going to try to compensate. It's going to, increase that systemic vascular resistance. So initially, that SVR is going to be elevated because the body is trying to compensate, trying to hold on to that blood pressure by causing vasoconstriction. But then it's going to lead to that heart struggling. Okay. So let's look at it again. Blood pressure depends on cardiac output times systemic vascular resistance. If one of those drop, your blood pressure will drop. Okay. Now let's move on to preload. Preload is the volume of blood returning to the heart. So think of preload as how full the heart is before it squeezes. So the more preload, so the more blood returning to the heart, the more stretch of the heart. But too much stress is going to cause congestion. Okay, so let's look at it. When preload is low, that means that there are lower amounts of blood returning to the heart. And that would be caused by bleeding, dehydration, you don't have enough volume, diuretics, which is causing you to have less volume, or septic vasodilation. And so the signs that you will see on your patient would be hypotension, tachycardia, flat neck veins. And so when your patient has a low preload, you're going to see orders for fluids. Okay. Now, when the preload is high, that means too much blood is returning to the heart. And that's caused by heart failure, fluid overload, renal failure. And your patient is going to have signs of like crackles, JVD, which is jugular venous distension. They're going to have edema, and they're going to have an elevated wedge pressure. And we're going to talk about that in a little bit. So when your patient has JVD, edema, crackles, you're going to think fluid overload. You're going to be looking for an order for diuretics. So remember, low preload, meaning not enough blood returning to the heart, you're going to give volume. High preload, meaning there's too much going to the heart, you're going to see an order or receive an order to remove the volume, possibly through diuretics. Okay? Now let's move on to afterload. Now, afterload is the resistance the heart has to pump against. So think of how tight the arteries are. So if your afterload is high, that means the heart has to work harder to pump against that resistance. If the afterload is low, then the blood pressure is going to drop. Okay? So let's look at it. High afterload, too much resistance, the heart has to pump against. And those causes could be from hypertension, vasoconstriction, cardiogenic shock compensation. Okay. So the treatment you'll see are vasodilators to kind of lessen that squeeze, okay, from that high afterload, that resistance that the heart has to pump against. Now, on the other side, low afterload, meaning too little resistance, the heart has to pump against. And a classic example would be septic shock. So the vessels are going to dilate, the systemic vascular resistance is going to drop, and the blood pressure will drop. And you'll see orders for pressors, okay? And those pressors are going to cause vasoconstriction. Now let's move on to wedge pressures. Now, wedge pressures, it's really pulmonary, capillary wedge pressures. And that reflects the left heart filling pressure. And so a wedge pressure measures the left heart ventricle filling pressure. And that's going to determine heart failure or how well the heart is pumping, and the severity of it. And then in addition, when you're looking at wedge pressures, it lets you know fluid volume status, due to that fluid backup. And so wedge pressures is going to let you know if the heart is pumping effectively. It lets you know the filling pressure of the left ventricle, and it's going to let you know if there's any kind of fluid overload due to fluid backup. All righty. So your wedge pressure is between 6 and 12 millimeters of mercury. Some books may say 4, but here we're using 6 to 12. So a high wedge pressure is going to let you know that there is left-sided heart failure. So it means high wedge pressure means that the heart is just not pumping effectively. A low wedge pressure is going to let you know that the patient has hypovolemia. So when you see on the NCLEX low blood pressure and a low wedge, that means that we're having a volume problem. If you have a low blood pressure and a high wedge, then that lets you know that there is a heart failure problem. And, based on, they both, the patient, two different patients may have low blood pressure, but if one has a low wedge and the other one has a high wedge, that's going to change the treatment. Okay. So you're going to be expecting or anticipating two different treatments. Now let's move on to pressors. Pressors tighten blood vessels. They increase SVR. Remember, that's systemic vascular resistance. They increase blood pressure. So you may see on the NCLEX pressors like norepinephrine. They use that in septic shock. It's a vasoconstrictor and it raises blood pressure. You may see dopamine. Dopamine is used for severe heart failure. It's like a short-term treatment, but dopamine will raise your blood pressure and raise cardiac output. And then you may see phenylephrine, which causes vasoconstriction, which will also raise the blood pressure. So any kind of constriction is going to raise the blood pressure. And so remember, pressors they don't fix volume loss. So if the person is hypovolemic or dehydrated, it's not going to fix volume loss. It's not going to fix a weak heart muscle. So if you're having heart failure, it's not going to fix it. But it does increase vascular tone to try to raise up that blood pressure and that cardiac output. But you have to fix the problem. We can give medicines, but if we don't fix the underlying problem, the medicines are going to be useless after a while. And I say that to say, when you use pressors or you receive an order, for pressors to give to your patient, if the patient has just a septic shock. Well, septic shock, vasodilation, a lot of the times, you're going to need to give your patient fluids. So you don't want to give a pressor without restoring volume. Because if you give the pressor and there's no volume to increase that cardiac output, so just remember, if the patient has septic shock, you're going to give fluids and then the pressor. Okay? So let's try to put all of this together. Now, before I start on some, I guess, mini questions, uh, remember, if there is a low blood pressure and a low wedge, and remember, a wedge is the left ventricular or left heart filling pressure, you have a volume problem. If the patient has a low blood pressure and a high wedge, that means that the heart isn't pumping effectively. So it's a pump problem, a heart failure problem. If the person has decreased systemic vascular resistance, so that's the vessels are dilated, that's going to lead to vasodilation, which is going to drop the blood pressure. And so you may see an order for pressors, which is going to cause vasoconstriction, which is going to raise the blood pressure. So let's do some mini cases. Number one, you have a patient, blood pressure 78 over 40, their MAP is 53. That should let you know, it's under 65. So that means that there is reduced organ perfusion. The heart rate is 110. They're cool and clamping. So that's letting you know that there's a perfusion failure. So you may see orders for fluids or pressors, vasopressors, depending on what's causing this. But there is an organ perfusion problem just by looking at the map. Number two, patient's blood pressure is 140 over 90. Their heart rate is 48. So the low heart rate means that there is low cardiac output. And your patient has the symptom of dizziness. So you know that the patient has a low cardiac output because of the bradycardia. And you may see an order for atropine that you'll have to administer to your patient. Number three, you have a sepsis patient. Okay, so you're going to be thinking vasodilation. So you have a sepsis patient. The blood pressure is 82 over 50, heart rate 120. Their skin is warm. So we knew from when we saw sepsis, you're thinking low SVR, low systemic vascular resistance, which means that the vessels are dilating, and you will anticipate fluids and pressors. Remember, Doesn't make any sense to give a pressor if you didn't restore the fluid volume loss. Okay? And you'll see that with your patient with sepsis. All right, number 4, blood pressure 78 over 40. Their wedge is 4. Remember, a wedge measures left ventricular filling pressure. If it's low, the patient has hypovolemia and their heart rate is 120. So they're going to have low preload. What's low preload? Preload was the amount of blood returning to the heart. Well, it's low. So you're going to anticipate an order for your patient to receive fluids because they have hypovolemia. Number 5, patient's blood pressure 78 over 40 again, but their wedge is 22. Remember, the normal wedge was between 6 and 12 millimeters of mercury. So with a high wedge, that means that they're having heart failure. And then they have crackles. Alrighty? So there is a high preload. What's preload? Too much blood returning to the heart. And they have a pump failure. So they're having heart failure. So you're looking at the blood pressure and you're saying it's 78 over 40, but you do not give fluids. The person has crackles, they have a high preload, too much fluid going into the heart. So you do not give fluids. You're going to anticipate an order for an ionotrope and like dopamine, which is going to raise the blood pressure and increase cardiac output. No fluids. All righty, last patient. Patient has a blood pressure of 80 over 50. They have warm skin. They have a low SVR, so they have a low systemic vascular resistance. So your mind should be thinking vasodilation. And they have a normal wedge. So they don't have heart failure and they don't have fluid overload. So warm skin, vasodilation because of the low SVR, you're thinking, man, sepsis. So you're going to anticipate giving the patient fluids and some pressors to increase that blood pressure and that cardiac output. All right. I hope those many questions kind of helped. But when you're looking at, hemodynamic numbers, right? You're really going to have to ask yourself several questions. What's the MAP? Remember, MAP is mean arterial pressure. So what's the MAP? Is perfusion adequate in your patient? Is the preload low or high? Remember, preload is the amount of blood returning to the heart. Then is the pump weak? Does the patient have heart failure? Okay. Is the resistance too low or too high? Remember, systemic vascular resistance. If it's too low, there's vasodilation. If it's too high, it's vasoconstriction. Um, does the patient, is the patient problem a volume problem? Is it a pump problem? Is it a vessel tone problem? Is the patient, vessels constricted or dilated? And then it's what intervention is going to restore perfusion. Is it going to be fluids? Is it going to be diuretics? Is it going to be ionotropes? Is it going to be pressors? That's really what the NCLEX wants to know. Do you know? Do you have, that's the NCLEX mindset. That's how the NCLEX is. So I hope that this helped. Um, you know, hopefully this kind of lessens some of that intimidation that you may feel when it comes to hemodynamics. Hopefully with this video, it makes sense. So if it does, please comment volume, pump, tone, or map greater than 65. And I really hope that I kind of broke it down. You may have to listen to it, once or twice, but I hope that, made those terms easier for you and it's going to help with testing. Um, before, I like to do like NCLEX style questions, scenarios, trying to pull it all together. But I'm going to do another video before that about perfusion. Now, yes, hemodynamics, perfusion is part of hemodynamics, but typically in nursing school, perfusion is kind of talked about in the beginning, your fundamentals. and then or your med surge 1, and then you get to hemodynamics when you're in your advanced med surge, kind of like your your last year, your last semester, your ICU rotation. And so I'm going to do that one next. And then I'm going to do more scenarios, just pulling all of the cardiac priorities together. Like I always say, this is really to help you, study smarter. So if you like the video, please like, please subscribe, please comment, because all of this is really, to help you do well in school and on the NCLEX so you can test like a pro. And so until next time, happy studying from Nurse Ed Scholar.